And then Renee, would you mind introducing yourself to the group?
Not at all. Renee Bolio Banks, Indigenous Cause, Jaganashamong, Zibikwe Indigenous Cause Indigo. So my birth name is Renee Bolio Banks, and my spirit name is Zibikwe, it's River Woman. I'm from Leech Lake and the Eagle Clan. I've been at NACC for a little over 4 years, and I'm an elder resident. So it's nice to meet you all. Miigwech.
Thank you. And Dr. Robbie?
Hi, I'm Kari Robbie. I'm a family practice and addiction medicine physician here at NACC, and I work closely in the MAT program.
Tina?
My name is Tina, harm reduction manager here at NACC.
Thank you.
I'm Nikki Jardina. I'm the infectious disease nurse at NACC.
And I'm Lindsay Cancuni. I'm the community and tribal engagement specialist at NACC. We also have Michelle Corcoran, who will be joining us shortly. She's on our ECHO team. She's our MAT nurse manager. So I'll also start with some announcements before we start with the presentation. Okay, so welcome to Midwest Tribal ECHO. Today we have Justin LaBeaux, the program director of Avivo Village, talking about best practices to help end homelessness. Just a little bit about NACC. So the Native American Community Clinic was established in 2003. We're an FQHC located in the heart of the urban indigenous community, right on Franklin Avenue. This is a list of all the services that we provide. This is all of the current open positions at NACC. So if you go to the website down at the bottom left, you can read more about all of these positions. Some session guidelines, please no protected health information. If you could make sure you're muted if you're not speaking. If you're able to turn on your camera and willing, we would love to see your faces. If you could let us know who you are in the chat as well, then I can send out the evaluation survey at the end. So name, title, organization, and email would be great. And then some upcoming echoes that we have. So September 6th, we have Dr. Ntaba doing his Beyond Bedside Manner presentation. And then Dr. Sandra Comstock will talk about Hygiene for All program on September 20th. This is a list of other echoes that we recommend that cover similar topics. And then we do offer continuing education credit for those who are eligible. Just make sure that you do give me your information in the chat so that I can send you the survey. That just needs to be completed to receive that credit. Just a reminder of the X waiver removal. You would need a total of 8 hours of training on OUD or SUD to get certified, and the credit from these ECHO sessions does count. And if you want more information, there's the link at the bottom of this slide. And then finally, case presentations. If you have a case presentation to offer, just let us know. They make for a great conversation. And I think that's it. So with that, I will stop sharing and I will hand it over to our speaker today. Welcome, Justin.
Hey guys, thanks for having me. Lindsay, should I share my screen? Is that how the best way to do this?
Yeah, that works great.
All right. 1 second. All right, can everyone see the screen okay? Please. So My name is Justin LaBeaux. I am the program director for Avivo Village and the street outreach program at Avivo. So today's presentation is going to be about Avivo Village, kind of how it came to be, and some of the ideologies that went into creating this program. So first, who is Avivo? We are a 501c3 nonprofit located throughout the greater Twin Cities area. So not just in Minneapolis, we have locations in Bloomington and Crystal and St. Cloud. Our main campus is off of Chicago and Franklin, 1900 Chicago over South. And then Avivo Village is in the North Loop. So we have 3 service area divisions: chemical and mental health, employment services, and then the ending homelessness division. So Avivo Village falls within the ending homelessness division, alongside street outreach, who actually offices out of Avivo Village as well. So it's nice to have them on site to help triage things. And then we also have site-based and scattered site housing within the ending homelessness division. So today's presentation will include an anti-bias lens, housing first and harm reduction, the evolution of a housing program, the hotel to homes, and then finally, Avivo Village. So towards the beginning of 2020, we found our community was in crisis. We had a large number of folks experiencing unsheltered homelessness, which isn't necessarily new for our community. But what was new was how visible folks were and how frequent encampments were popping up in the public eye. So we began to see encampments pop up through the city much more frequently than we had in the past. We are experiencing an affordable housing shortage and still are experiencing that today. COVID-19 was on the horizon. Lots of uncertainty and anxiety filled not only our community, but communities across the globe. And then in addition to COVID-19 looming, we were also in the midst of an hepatitis A and an HIV outbreak amongst our unsheltered community. So as an agency, we tried our best to look towards solutions with an anti-bias lens. The models we utilize here at Avivo Village are the housing first model and the harm reduction model, amongst others. But these are the 2 primary modalities that we operate within. So housing first is a homeless assistance approach that prioritizes providing permanent housing to people experiencing homelessness, thus ending their homelessness and serving as a platform for which folks can work on other aspects of their lives, improve personal goals and improve their quality of life. So it's guided by the belief that people need basic necessities, i.e. food, a place to live, before they can attend to anything less critical, such as budgeting properly or substance use issues, things like that. So that's essentially the housing first model. There's a lot of barriers that you can fall in while pursuing housing. We try to start with housing so that we can work on those barriers while you're out of survival mode and in a safe place. So harm reduction is the next modality that we work within. So it's an evidence-based approach utilized to engage with folks who use drugs while triaging life-saving tools, resources, and information to empower positive change within an individual's life. This is a judgment-free approach that allows us to meet residents where they are at. So we were asking ourselves, and more importantly, doing our best to amplify voices of those experiencing homelessness. What are some of the barriers we are facing today working within our current housing system? Are we contributing to these barriers at all, intentionally or unintentionally? How are we how do we factor into the system and the barriers in place? So during the summer of 2020, there was a large scale encampment growing over south within Powderhorn Park. So there's actually 2 encampments in Powderhorn Park. So Avivo, with funding from the state, conducted a survey of the 2 encampments over a course of 3 days in the summer of 2020 to find out who was living there, where they were living before moving to the park, and what services they needed but didn't have access to currently. One of the most important reasons for the survey was to find out who's there and what resources folks needed to be connected to. But also, we want to amplify the voices of folks who are experiencing homelessness and consider them experts on their own lives and have them let us know what a solution might look like. So sifting through the surveys and the data overwhelmingly displayed the need for a housing first model. It's not realistic for individuals to get other aspects of their lives in order until they have a safe place to rest their head at night. Folks cannot thrive while they're stuck in survival mode was kind of the recurring theme that we heard when we chatted with folks. So at one point in 2020 at the camp, there was over 500 tents spread across 2 separate encampments. Service providers during the surveys were able to connect with 282 individuals. Of those 282 individuals experiencing homelessness who were surveyed, 45% of those identified as Native American. So Native Americans are disproportionately likely to experience homelessness. They comprise of 1% of Minnesota's total population, but 13% of the homeless population in Minnesota. So Native identifying individuals are even more likely to be living in encampments as opposed to shelter for a variety of different cultural and historical reasons. So folks have different identities that make them who they are. It's through these different identities that they can experience interlocking inequities. So Avivo Village was born of the idea to be as low barrier shelter as possible, all while working to address these interlocking inequities. Intersectionality is a metaphor for understanding the ways that multiple forms of inequality or disadvantage sometimes compound on themselves and create obstacles that are often not understood among conventional ways of thinking. So essentially, it's systems of inequality based off of gender, race, ethnicity, sexual orientation, disability, class, and other forms of discrimination intersect to create unique dynamics and effects. So an example of this would be when a Muslim woman is wearing a hijab and is being discriminated, it would be impossible to disassociate her female from her Muslim identity and to isolate the dimensions causing her discrimination. So taking a step back and reflecting as an agency, do our programs and policies contribute to oppressive systems? We did our best to listen to the needs of the folks in their community as to what the barriers and challenges they were facing. Centering our work around cultural humility, dignity, and respect for all, acceptance, choice, empowerment, and authenticity. But how do we do this? By integrating a continuum of low barrier services, including mental health, substance abuse, and primary care services, by recognizing that one disorder does not necessarily present as primary. So the challenge is bringing an anti-bias lens to every aspect of the work that we do. The evolution of a housing program. Stage one was standing up an emergency hotel to homes program amidst the uprising after the killing of George Floyd. Many of you probably remember back in May of 2020, there was a larger encampment off of Hiawatha near the LaBeaux Bridge. During the unrest, different service providers worked together to transition 100 individuals from that encampment to the Baymont Inn and in Coon Rapids and the Super 8 in Brooklyn Center. This wasn't just an evacuation plan for folks. This was the beginnings of a housing program. So the evacuation took place in a matter of 12 hours. And in that time, there was program development, paperwork that was done, and the beginnings of a hotel to home program. Each individual who entered this program was connected to case management, mental and chemical health professionals, as well as primary doctors. It was important that we framed this through the lens of housing. So the end goal was always permanent supportive housing for individuals. So as lots of work in this field is done, it was very on the fly and kind of ad hoc. So we had to make things work as we went. So as this was developing, we're asking ourselves, how can we create a safe space? And how can we make this culturally appropriate for folks and someplace where folks feel welcome and want to be? So understanding that uprooting folks from the community and asking them to relocate to a hotel in the suburbs is a traumatizing thing. We asked ourselves how we can create this safe space. We have culturally appropriate mental health clinicians, chemical health staff, and a medical team, staffed by over 20 support staff around the clock, 24/7 at the hotel. And then the modalities we tried to implement into this hotel to homes program were trauma-informed care. We tried to be as person-centered as possible, and then have it be a harm reduction space as well, which, as I'm sure you guys can imagine, comes with its fair of challenges when you're operating via a hotel where it's not a controlled space and you do have folks who aren't part of the program that are staying there, and then hotel staff. So it was kind of a juggling act, protecting folks' privacy, but also keeping them safe. So on the fly, with lots of help, we set up the hotel to home program within the course of 12 hours, which included 3 meals a day catered in from a nonprofit called Involve Minnesota. We have case management on site at the hotel, working from the lobby, private conference rooms, with individuals out in the community. So they were on site 5 days a week. The staffing model was 24/7 for resident advocates to be present and help residents with whatever they might need, even if it's past business hours. Collaboration with healthcare providers. I know the NACC was a huge help. And I know some of you were even at the hotel doing testing, COVID testing. So again, you guys were amazing. We had mental health and chemical health professionals on site meeting with clients, conducting assessments, and then making referrals to various other programs. Utilization of the harm reduction model. We incorporated wellness checks to each room every 2 hours just to make sure folks were okay, had what they need, had harm reduction supplies, and were being checked on, not using alone, all of those things. So, and then community and bonding. We spent a lot of time with folks at this hotel, developed a lot of close relationships, and a lot of community kind of came from that. So we put a concerted emphasis on housing. The goal was clear: to transition everyone from the hotel to permanent supportive housing directly from the hotel, with no return back to living in encampments or living outside. Of course, the pace at which housing happens relies on many different factors, but it's important that we face what lied ahead through the lens of housing as the end goal. So later in the summer of 2020, there was a reoccupation of the Wall of Forgotten Natives, and this was right after the encampment closure near Indigenous Peoples Task Force. So due to the success of the initial hotel to home program, utilizing the housing first model and harm reduction, we were afforded the opportunity to do so again. This time we had 62 individuals move from the second occupation of the Wall of Forgotten Natives to a hotel. It was the Baymont Inn in Coon Rapids, where they're connected with all those services that I listed before. So the wraparound services on site. So having done this model twice, both times kind of on the fly without a lot of prep time ahead of time to work out the logistics, we kind of saw that this is a model that works and that we can replicate and put more time and resources into to have a more robust offering for folks. So how can we think about ways to level up and innovate this model instead of being reactionary with our program development? What if we build this thing from the ground up? So here's a early picture of Avivo Village from above. We was created in partnership with White Earth Nation around Ojibwe informed meaningful epistemology, language, and symbolism. We also had extensive partnership with Red Lake Nation as well. Here is a early photo of construction of the tiny homes. So I wish it looked this clean all the time, but it does not. This is before folks had actually moved in. You could tell there's no room numbers, no street signs. Yeah, but this is just the early models. So much like the original Hotel to Home program, Avivo Village utilizes the same model that had proven successful at the Baymont Inn, but with more robust and more collaborative service delivery. So just like the Hotel to Home program, there was 3 meals a day delivered by Involve Minnesota. There's a heating container where the meals are stored. So there's not a designated meal time where folks have to eat. They can kind of pick and choose when is convenient for them in their schedule, and they can have a hot meal whenever they decide that is. After say like the lunch is delivered, we'll move the breakfast into fridges. And then if folks would rather have breakfast, if they're not feeling whatever the lunch is, they have the option for that as well. And then we do take dietary restrictions into consideration. So we have some folks that are no pork, some folks that are no dairy, and we can kind of accommodate that however is best for the resident. Case management on site Monday through Friday. The resident advocate staffing model is 24/7. So we have 1 supervisor plus 4 resident advocates on site at any given time. During first shift, which is 6 a.m. to 2:30 p.m., we also have the case managers on site, and they also bleed into second shift a little bit as well. So they're usually here until around 5. But then we also have relative intel security on site 24/7. It's a low profile security company, third-party security company that we utilize. So there's no uniforms, no badges, no weapons, anything like that, to try to be a little bit more inconspicuous and less threatening to folks. We have 3 different shifts at Avivo Village. So the first shift, as I said, is 6 a.m. to 2:30 p.m. Second shift starts 2 p.m. to 10:30 p.m. And then third shift, which is the overnight shift, is 10 p.m. to 6:30 a.m. And so in between all these different shifts, we have what we call a shift change, where we chat about need to know information to keep folks safe on the floor. If there's any residents that have maybe medical appointments coming up or court or a housing referral that they need to be at, we can relay that information at that time to make sure that everything goes smoothly and that the resident gets to where they need to be. We have a spiritual care advisor from the NACC named Adrian, who helps with various programming specific for Native American residents. And then we also have chemical and mental health professionals on site with the ability to complete comprehensive assessments and then make referrals to other programs as well. I think part of the leveling up, so to speak, for the village compared to the initial Hotel to Homes program. It was just like the community collaboration and partnerships with so many of the agencies that are here today that like really make this work. So we have MNsure navigators to help folks get set up with medical insurance, coordinated entry assessors on site, street outreach offices out of the village as well. And then, like I said, we just leverage the incredible support from other service providers. We have on-site health testing, wellness fairs, peer support professionals running groups, really a lot of different programming. And we work with providers within the community to kind of provide more programming and different programming. And we're always open to feedback about what will best serve our residents. So none of these things that I've listed are particularly new or innovative unto themselves. So what is new about this program is more so having the totality of these wraparound services in one location for folks to access in their own time. Kind of through this whole thing, we turned emergency response into innovation. Avivo Village is an indoor community of 100 secure private dwellings or tiny houses. For those of you who have been here, they kind of look like, I kind of think of them as ice houses almost. They're smaller, but they have a door that locks, window, bed, a desk, a chair, and then folks can customize it to be their own as well. And then we have storage. This is not here or there, but we also have storage pods in the parking lot. So anything that folks can't have in their unit or can't fit in their unit, we can store in the pods for them when they do move out into permanent supportive housing. So we operate as a transitional shelter with wraparound services and a high fidelity harm reduction with a focus and emphasis on housing. Harm reduction is a process of normalization. So I know this is a super cliche thing that people say in this field, but we're really trying to meet folks where they are at. So sobriety is not a requirement for Avivo Village. We always say we're not pro drugs, but we are pro keeping people safe. So we want to use every tool in our toolbox to do so. We utilize harm reduction as an evidence-based approach that is critical to engaging with people who use drugs while equipping them with life-saving tools and information to create positive change in their lives and then potentially save their lives. So we want residents who are coming to staff asking for clean kits or naloxone to do so with the same like mundane or have it be just as normal as they would if they were to come and ask us for laundry soap or disinfectant or something along those lines. We really want to normalize the process and the conversations around substance use. We want to use every tool in our toolbox to prevent potential overdoses, infectious disease transmission, improve physical, mental, and social well-being, and offer low barrier options for accessing healthcare services, including but not limited to medically assisted treatment, MAT services. So every Tuesday and Friday, we have a chemical health assessor on site completing Rule 25 chemical dependency assessments. And then they can triage and make referrals from there for folks who are interested. We partner with incredible organizations such as NACC, Southside Harm Reduction Services, Indigenous Peoples Task Force, Healthcare for the Homeless, amongst many, many other service providers to deliver the most comprehensive harm reduction approach possible to meet the needs of our residents. The primary modalities at Avivo Village are as follows. We want to be as low barrier shelter as possible while utilizing a trauma-informed approach. We have a heavy emphasis on harm reduction and destigmatizing drug use and conversations around drug use. And we want to be culturally responsive and supportive to our community. The unrest in Minnesota after the killing of George Floyd isn't new to our county. What was new is how our community chose to respond to that. So we said no to bias and oppressive programs, and we said yes to helping our community. The work continues. Some of the barriers we tried to remove for folks seeking shelter. So Avivo Village was kind of born on the idea to be a shelter for folks that don't traditionally seek shelter. So we tried the three main barriers that we tried to remove when creating Avivo Village. We call it the 3 Ps. So it's pets, partners, and property. Chatting with folks in encampments, we would hear that folks wouldn't want to seek shelter because they have pets and pets wouldn't be welcome in shelter. They have partners and they don't want to have to separate from the one person that they might feel safe with. And then property. We don't want to have folks have to choose between seeking shelter and then losing all their belongings. So folks can bring in their belongings to Avivo Village. You can't have, there's a limit to how much you can have in your particular unit, just for fire code and safety purposes. But we also do have, I think, 7 pods in our parking lot right now full of storage. So folks can store excess furniture, whatever they have that they're not going to be using within their unit in the pods until they do move out into their own permanent supportive housing. Sweet. And I think that's all I had. So if anyone has any questions about Avivo Village, the process, the program itself, be happy to answer any questions you.
How long can people stay there?
That's a great question. So there's no limit to how long people can stay here. The average length of stay we have found to be about 135 days, give or take. So a little over 4 months is the average length of stay for folks to work through some of the barriers that they need to move into permanent supportive housing. But there's no limit to, you have to be gone by a certain day. We just ask that folks engage with their case managers and kind of work towards housing. There's no like curfew. You don't have to check in and check out daily. This is their home. They live here. They can come and go as they please. The only GRH rule we have is that if you're gone for more than 18 days, we do have to discharge from the program and give the unit to somebody else on the waiting list. But that can be mitigated by just calling your case manager and saying, hey, I'm out of town. I'm still in the program. I just wanted to touch base. So that's the only caveat, is the 18-day policy. But outside of that, folks can come and go as they please. There's no limit to how long folks can stay. We've had some folks here for over a year. It's just kind of moving at the pace of the specific individual.
So how does one, do we refer, or how do they get engaged with your program?
Yeah, that's a great question. And it's kind of a confusing answer. So I'm going to ramble a bit. So most shelters kind of come through Adult Shelter Connect. They call Adult Shelter Connect and they can connect them to different shelters within the county. They have visibility into how many beds are open, and then can refer that way. Avivo Village is a little bit different because it's a transitional shelter and it's not a check-in, check-out type shelter. So the referrals come through outreach teams. And right now we have 11 different outreach teams or providers making referrals into Avivo Village. So as units open up, we have a rolling list of who is up next to make a referral, and say we have 3 folks move out this week. I'll send out an email to service providers and say, we have 3 open units. 1 goes to NACC, 1 goes to White Earth, 1 goes to Southside. And then from there, they can reach out from their own specific interest list and prioritize who they feel would be the best fit at Avivo Village. And then they can make the referral in that way. So it's a little bit more complicated of a process than just calling or just submitting a referral, but it is an approved list of 11 providers / outreach teams that make referrals into the Avivo Village. And then as openings come up, we reach out to those providers and let them know that they have X number of slots that they can fill. And then we work with them to fill those spots.
Thank you.
I have a question, maybe, and I don't think I missed this. Do you have a sense, you said that the idea is that people are going to transition to more permanent housing. Do you have, I'm sure that, what percentage of people actually, when they leave, do transition to more permanent housing? And is there a subset of people that don't?
Yes, I think that's kind of what we're finding now. So the stats show about 50% of the folks who have come through the program have ended up with signing a lease, keys in hand. Of the 50% that haven't, some of them are still here. So there's still 100 folks that are added into that total that could still theoretically move into housing, but it's about 50%. I should pull up the stats here too. It's about 50%. And then we are kind of finding a subset of folks who maybe have a little bit more barriers that they're working on, or maybe are just comfortable here and feel supported and safe. And the idea of moving out on their own, it can be a scary concept. So we kind of work with them on that. And there's no like pressure to, you have to take this referral, you have to do this. It's more so meeting them where they're at, as corny as that is, and just kind of letting them take the lead on what's best for them and just providing the resources for them to make that decision.
So that's interesting. So are you suggesting that 100% of the people who leave go into supportive housing?
No, there are other people who discharge for a variety of different reasons. We really try to do everything we can to not discharge people from this program, but there are times where folks will just not show up, or they'll maybe stay with a friend or a family, and then we won't see them for a few months. So then they will discharge that way. Sometimes they will voluntarily discharge. So it's not 100%. I would say about 50% or 60% of the folks that leave the program leave it for permanent supportive housing. Sometimes
that's very impressive, actually. That's very impressive.
Yeah, and sometimes it's folks who go to treatment or folks who go to jail. And then we still try to work with them so that they have a spot afterwards that they can come back to, so they don't have to revert back into homelessness.
That's a great statistic.
And there's just my contact information too, if anyone has any questions afterwards that they think of that they want to shoot over.
Justin, it looks like Julie put something in the chat. So just wow, Justin, thank you for this awesome community support, and we need this in Ramsey County too.
I agree. Some of our site-based programs are in St. Paul. And so I 100% agree. There's definitely a need for something like this in Ramsey County too. Unfortunately, that's well above my pay grade. So I'm just, I can put in a good word.
I have a question. I'm wondering what steps you've taken to like get everybody that works there on the same page about harm reduction in terms of like trainings and anyway, just because I know everybody sort of comes from their own place regarding beliefs on substance use. So yeah,
totally. So that's something that we really try to vet out in the interview process to make sure that folks kind of know what the program's about, what they're getting into, and all of that. So part of their onboarding process is they go through a harm reduction training that we did actually with the National Alliance to End Homelessness. They have this harm reduction training that a lot of our leaders at Avivo went through, and now we're certified to do the trainings ourselves. So we go through that training, which encompasses everything that you could need to know about harm reduction. So we try to whittle it down to specifics, what's applicable at the village. Everyone at Avivo Village is naloxone certified through the Steve Rumler's Hope Network. We also have on-site naloxone trainings for staff and residents monthly on the second Monday of every month at 3:30 p.m. So if anyone is interested in that, I can always send out an invite too. It's open to the community. And then everyone is also CPR certified as well. We do mock overdoses to practice how we would respond in that situation, to make sure everyone knows all the various roles, what to do, have it be second nature so that it's not a, fight or flight mode. So we do a lot of onboarding trainings around harm reduction. And then we also partner with other agencies like Steve Rumler's Hope Network, Continuum Care Center here over North, Southside, other programs to really implement that into our program.
Awesome, thank you.
I have a question that brings up, that makes me think of, do you see how many overdoses are you seeing like on site, and like how often does that come up?
Yeah, it really ebbs and flows. I think we've had since opening. So sorry, we opened in December of 2020. So since opening, I think we've had 170 overdoses at the Village. And they kind of come in clusters where, like, knock on wood, we haven't had one in about a week, but then, we might have 2 in the same day. So we constantly have to be ready and on guard and all of that. But we do kind of find it comes in clusters. So if we know that there's maybe a batch that we need to be aware of, or if there's an influx of income at the Village, things like that, just to be more aware that and more, I guess, hyper vigilant around that sort of thing.
You do room checks to make sure nobody's overdosed in their room?
Yes. Sorry, I think I had that in my notes and I just skipped over it. We do 3 room checks per shift. And then outside of that, we work with folks. So if potentially, say, somebody just got released from jail or from treatment, we have candid conversations with them about use and ask if it's okay. Can we do extra checks? We just want to make sure you're okay, where you're safe, you're not using alone. So there are certain situations where we'll do extra checks, or we'll have folks kind of hang out with us in the common area, maybe watch a movie. But the standard is 3 checks per shift. So 9 checks a day, but usually more if the situation calls for it. And then, let me see here. I have the shift guide here. Oh, I'm not on camera. Never mind. So I have the sheet of paper. It basically goes through everything.
Actually, do you want to take the PowerPoint down, and then we can see your face and everybody else? Yeah, perfect. Now you'll be on camera. Thank you.
Okay, sweet. So we have these. I'm just making sure there's no private information on here. Yeah. I don't know if you can see this. It's basically a checklist for the room checks. So we have first shift, second shift, third shift, and you fill it out as you're doing the room checks. So if first shift is seeing something that maybe second shift needs to be aware of, that'll be communicated in shift change and in Microsoft Teams. Everything will be documented, but it'll also be on the room check shift logs for the next person, so that they're aware of what they're walking into, things to be aware of, yeah, that sort of thing.
And Justin, there's a comment and a question in the chat. So Stacy says, thank you for your informative presentation. And then Miranda asked, how do you support your staff after an overdose, your staff / residents? Yeah,
that's a really good question. We are really good at leaning on each other, and we after every overdose response, we have a debrief, and we talk about how everything occurred, who found the individual, who called 911, who worked on the individual, who loaded the Narcan, all the different jobs. We kind of break down how things went, what we could do to improve if there's anything that didn't go smooth. And then we just check in with folks to see how they're feeling and give them space to feel that, because it is, we've had 170 since opening, and you never really get used to it. And it's always a traumatic experience. So we want to hold that space for folks. I know this isn't a good answer, but sometimes like after a particularly hard day, we'll order food for folks and kind of have a community meal. But outside of that, we just really try to hold space for folks to have conversations about how they're feeling. If they need to take, a half hour or whatever, if they need to step away, like that's totally okay. We get it, and we can help support each other through that. And part of that too is like when we do the naloxone trainings, we have a lot of times we'll have residents there with us, just to make sure that we're all getting like the same information, so that in the event of an overdose, we're not having conflicting like ideas of how to respond. We're all operating from the same like toolbox given to us by the experts.
Thank you. Does anybody have any other questions or final comments for Justin?
I just want to double check too. So if somebody's part of a couplehood, they get separated out into their own units, right?
Correct. So each individual would get their own unit. We do have couples that stay here that they'll like stay in the same unit and use maybe the other unit more for just like storage, as long as it's not like too cluttered where it's going to impact fire code. But we do have a lot of couples that they'll each have their own unit, but they'll stay in one so they can stay together. So that's totally okay.
Okay, thank you. Because I see a lot of people don't like to leave the other partner on the street. So I just want to clarify.
Yep, totally.
Justin, I was going to ask too, is it okay to share your slides with the group if people wanted to see those and with your contact information?
Yeah, for sure.
Okay, cool. Thank you. Any other questions? All right, well, we're getting to 1 o'clock, so I think we can wrap it up. Thank you so much, Justin, for your great presentation.
So thank you so much for the work that you're doing. We just love that you are there. So appreciate it.
Thank you guys. I appreciate it. It's really nervous to not a public speaker, but you guys made me feel comfortable.
Fantastic presentation. Thank you very much.
Thank you, Justin. You did great.
All right, and thank you everybody for joining today. Our next echo is going to be September 6th with Dr. Ntaba talking about beyond bedside manner. So please come back. Thank you.